Welcome to Advanced Patient Care, a podcast by Vance Thompson Vision. Today's podcast is featuring glaucoma, and I'm your show host, John Berdahl. I'm here with Lori Provencher, Mike Greenwood, and Justin Schweitzer. This podcast is here to bring you the latest advancements, cutting-edge research, practical tips that you can apply to your clinic practice right away so you can take care of patients the way they deserve to be cared for. So if you're ready to expand your knowledge, stay ahead of the curve, elevate your practice, you are in the right place, and here we go. Let me go around the horn. I'm John Berdahl. I'm an ophthalmologist, do cataract, cornea, refractive, complex IOL at Glaucoma here in Sioux Falls, South Dakota. Mike?
Michael Greenwood, Vance Thompson Vision, practice very similar to John up in Fargo, North Dakota.
Lori?
Lori Provencher. I'm in Omaha, Nebraska. I do cataract surgery and glaucoma surgery.
And Justin?
Justin Schweitzer, an optometrist. I work alongside John, managing glaucoma, cataract, cornea, and refractive surgery patients.
All right, well, we're going to talk about diagnostics first for about the next 10 minutes or so. So let's start with this. What is glaucoma? Lori, tell us what glaucoma is.
I like to just explain it the way I explain it to patients. I think we all know, but just a nice thing to say is I just say it's a disease of the optic nerve. I don't talk about pressure necessarily. I just say that little cable that connects your eyeball to your brain has a disease at the nerve head. And the best way that we treat it right now is pressure control. And I say it typically results in visual field loss if left untreated.
Great. And, I think the point that you're making there is don't overcomplexify it. It's a serious thing. It's the second leading cause of blindness, but don't overcomplexify it with patients. What they really want to know is, you know what you're doing. You're going to take care of them, and you're going to prevent them from going blind. Now, Justin, I'm going to maybe ask you the hardest question of this segment. In the diagnosis of glaucoma, what information do you need? So what I'm really asking for is, what do you need in a family history? What do you need in a medication history? What do you need in a past medical history, if anything? And then what diagnostic treatments, what diagnostic tests do you need? And if you miss one, somebody else will pick you up. But let's start with the big picture. What is everything that you need? And then let's dive into the specifics.
Yeah, I'll whip through them, but yeah, if I miss something, please jump in. I want to know family history. Main question I want to know is, did you have a family member go blind from glaucoma? I care about that a little more than if family members had it, because one is really advanced, one is not so advanced. When we think about diagnostic tests, obviously want to know what their highest pressure has been in the past, what their current eye pressure is. We want to get a visual field. We want to get an OCT. We want to know how thick their corneas are. We want to do gonioscopy to see what the angle looks like. So those would be some of the main ones. I want to know if they've been on any previous treatments before. What have they tried from a drop standpoint? Have they had any laser done previously? Have they had any surgeries done that involve glaucoma procedures? Those would probably be the overarching ones. Obviously, we're going to take a look at the nerve and see what the cup to disc ratio is. What am I leaving out?
Did you say OCT?
I said OCT.
You did say OCT? Okay. Good. And then what about corneal hysteresis?
Yeah, I missed that one. So I do like that particular one, more for risk assessment, right? Not to diagnose, but I love hysteresis for helpful with risk assessment.
How important is having corneal hysteresis as part of the workup?
For me, I don't think I could practice the way I do right now without it. I think it's a small piece to the puzzle. All those things I talked about are puzzle pieces in diagnosing and managing patients. But I think it can be helpful in deciding between, do I just start a drop or do I become more aggressive and recommend a more aggressive surgical procedure, along with looking at all the other puzzle pieces as well.
Justin, if you're an optometrist in Murdo, South Dakota, do you buy corneal hysteresis?
It's not my first thing. I want an OCT first. I want a visual field. I think those things are more important. I want to know what corneal thickness is. I think those would be more important than hysteresis. But if I'm adding to my arsenal of technology for glaucoma, it's one on the list.
Okay, so I'm going to put you on the spot a little bit more. In order: visual field test, OCT, gonioscope, corneal hysteresis.
What's my top one out of those?
Put those four in order. What what do you need if you're practicing in rural upper Midwest? Which one of those do you buy first? What do you buy second? What do you buy third? What do you buy last?
OCT, visual field.
Gonioscope, then corneal hysteresis? Gonio mirror, then corneal hysteresis?
Oh, yeah, then goniomy would be 3, then hysteresis 4.
Okay, good. Lori, do you agree?
I'm going to disagree on the top two. I still think I'd buy a field first. And that's because at the end of the day, that's your best reflection of function. And it's going to help you decide how worried you really need to be as far as their functioning. Obviously, I rely heavily on OCT and I love corneal hysteresis, but I think when it comes to screening for bad stuff, the field is still would be my preference.
Yeah,
I'm gonna
yeah, and
challenge, I'm gonna challenge all of them because I would do gonioscopy first. Because if the angle's closed, it's going to dictate how you're going to treat this patient. So, regardless of how bad their pressure is, so I'd probably put that one.
sounds great. And that question is kind of like if you were stuck on an island and only could eat one food for the rest of your life, which one would you eat? And so I know it's not a fair question, but I do think it is helpful for us to think about the priority of technology because we're faced with those questions all the time. Justin, you said something that I love about asking the patient, have you had someone go blind from glaucoma? And that the answer to that question puts me down one of two routes. If they say yes, I know that patient's terrified because they watched their mom go blind. And what I like to tell them is, we're not going to let you go blind from this disease. You're here, assuming it's true and they're not end-stage glaucoma, we're going to almost certainly be able to prevent you from going blind and give them reassurance. However, if the patient says, no, my mom just had glaucoma, they may not be taking their disease as seriously as they should because they don't notice it. And then I kind of take a different approach and say, hey, this is a serious disease. It's the second leading cause of blindness. Our job is to do a great job evaluating you and implementing the right treatments. Your job is to do those treatments or tell us if you can't. And if you can't, we'll find something else that you can do. So I really like how you phrase that question because it puts me down a different road when we're talking with them. Okay, so Mike, you talked about gonio as your first tool of choice. So let's talk about narrow angle glaucoma for a second. We don't see tons of that up in the upper Midwest, but we see some. What's the treatment for a patient that's got narrow angles?
Basically, opening the angle, right? So it's variable. If they're, a really young person and they just have a really small eye and then angle's kind of closed, you're going to work at different ways to open that up. You get someone who's 50, 60, 70, 80, 90 years old, they still have their natural crystalline lens. Taking out that cataract is going to solve that problem, 90% of the time. And that up here is probably what we're seeing most of is more this phacomorphic part where the cataract or their natural lens is causing that narrow angle to form. So to me, removing the natural lens.
And we'll talk more about that in the therapeutic section. So we'll come back to this question on the what would I do if it was my eye section here coming up. What else are you looking for on that gonio exam, Mike?
Am I looking for more on the gonio exam? Is that what you said?
Yeah, open or closed. What else are you paying attention to?
So pigmentation is helpful. We're still, we're getting to the point on the diagnostics where we can view the outflow pathway a little bit more. And right now, kind of our poor man's test, so to speak, of what we have is where is the pigment if it's kind of spotty. And so if it's spotty pigmentation, you might say like, okay, that's where the greater outflow pathway is. And so that's maybe where I'm going to make my target when we start, again, talking about therapy or treatment. So those are kind of things, obviously making sure there's no PAS, those types of things that are blocking outflow. If they've had previous surgery, making sure that, exactly. Mm-hmm. Yep.
I want to add a comment to the PAS thing because I'm a huge gonio nerd, so I'm with you, Mike. But like when it comes to treating angle closure, it's really important to stage them properly. So if they're just narrow and they don't have PAS or high pressure yet, it's according to like the ZAP and Analyst trial, it's still reasonable to observe those people. You have to have a conversation with the patient about their other risk factors and their lifestyle. But once they do start to form PAS, that means that they're getting enough intermittent contact in their angle that they're getting sticky adhesions. And so you have to take their disease more seriously. And that's when they're moving into sort of a different category of treatment, like Mike was talking about, where we're applying the Eagle trial, where they're either getting an LPI or more likely, and I think better, is a cataract extraction, like Mike said. So getting that right staging is going to, again, diverge you down two different paths on how you're going to treat that patient.
Great. And we've got about a minute left in this diagnostic part. I bet we go for a minute and a half. Lori, I'd like you in about 45 seconds to say, okay, I'm getting visual fields. How do I know if they're really getting worse?
Tough. I think I like to have kind of corroborating data. So if their OCT is looking worse, if their pressures are, in my opinion, out of control, that makes me feel a lot more comfortable. I think you'll never be judged for having a patient back to repeat the field, just to give yourself and the patient some reassurance that you're making the right next step.
Great. So I feel the same way. If I'm going to cut a hole in somebody's eye, I better make sure that it's not because they just had a bad day on a visual field. It's a very artistic test. I agree with you that it's the most important because it is the one where the rubber meets the road and the function of a patient in their life isn't dictated by their OCT or their gonioscopy. It's dictated by their visual field. Justin, same thing with OCT. How do you give us some tips for making sure that when we're seeing progression on OCT, it's real? And how you correlate that with visual field. And then we're going to move on to treatments.
Yeah, I think, repeatability is a big thing. A lot of these guided progression analysis pieces help a lot to be able to look at multiple fields on a trend line. I think with an OCT, it's important not to get caught up in looking at color. It's very easy to look at the color of an OCT and say, oh, green means normal. And you'll have patients that are progressing right, in front of you with what we call green disease, where that RNFL, those values are declining. Right in front of you, but they're staying green. And so pay attention to the values, look at the numbers, and then pay attention to the eyes. They should be fairly equal on numbers. Just like we look at CD ratio, if you have a 0.5 cup in one eye and a 0.7 in the other, that's a red flag. If you have a 83 average RNFL in one eye and a 93 in the other eye, that's a red flag to me. So those are things that you just want to pay attention to.
Great news. I don't pay attention to colors at all because I'm colorblind. Red and green looks the same to me, so give me the numbers, baby. All right, let's move into treatment modalities. So, Mike, tell us all the things that we can. I put Justin on the spot before. Tell us all the things that we can do for treatment for glaucoma.
Nothing.
Yeah.
Topical medications, eye drops, injectable sustained release medications, laser, surgery, and surgery can be MIGS, minimally invasive glaucoma surgery, or more invasive glaucoma surgeries, which would be like tubes, trabs, those types of things. And we can also do kind of cyclodestructive procedures, which sounds really bad, but basically it turns on the faucet, makes sure the eye doesn't produce too much fluid. I think I covered them all.
Great. So, Lori, what do you think is the ideal progression of treatment? So, and of course it varies patient to patient, but let's just say vanilla glaucoma, if there is such a thing. A patient comes in, they're 57 years old, they've got a pressure of 25, and then we're gonna know that our crystal ball is that they're gonna progress over time. Which treatments are you starting with and inserting along the way?
Yeah, so I think for historical context, it used to be meds, surgery, like mean bad surgery. And now we have the option, or we kind of moved into this era where it's like you can either do meds or SLT. They're both good. And now that we're getting more data on the power of SLT and how it's actually protective for reducing surgeries and reducing field loss, it's the algorithm to me has flipped to where SLT should really be elevated as a first line option. It's not going to be right for everybody. Some patients are not going to like SLT, or it's not going to work for them. But to me, it's above meds now. And then you can always insert at various time points meds. You can insert drug delivery, and MIGs are great throughout the treatment algorithm, depending on disease severity, but definitely at the time of cataract surgery.
Great. And Justin, one of the things that we talk about a ton is compliance. And do patients use their eye drops? Now, compliance, I don't really love the word because it feels like they're out of compliance and they did something wrong. Adherence may be a better word. But I sometimes wonder, have we overstated the compliance issue? I know there's data out there that says maybe up to 80% of people don't do their eye drops right. 50% is kind of what we say. I believe that could be true. I generally get much better at flossing for the week and a half before I go see the dentist. And I imagine our glaucoma patients think of us the same way. But are we overplaying compliance, or is it for real?
Yeah, I mean, I think the data would say it's for real. I question a little bit. A patient that's on one drop, I do believe it can be fairly compliant. Once you start adding drops, 2 drops, 3 drops is where I think we run into compliance issues. But I also don't just think about drops as a compliance factor or adherence factor. I think of quality of life with them too. And it's that balance. So it's quality of life and adherence. So that's great if they're taking their drops every day and they're on 3 drops. But if they come in and their friends are telling them their eyes are red and their eyes are burning and hurting, that matters as much to me as whether they're taking them or not. And so I think it's a balance of adherence as well as quality of life. And can we minimize that with the treatment options we have available now?
Justin, we published a paper together on the challenges that eye drops present medically to the surface, specifically dry eye. In 30 seconds, walk us through the take-home of that.
Well, we did it. It was a MIG study, really, and we looked at, patients that had ocular surface disease ready to undergo cataract surgery plus stents. We ran them through a quick OSDI, so ocular surface disease index. They scored about a 40, which is in the severe level on that index of symptomology. They underwent cataract surgery plus a stent or stents. These patients were only on about 1.5 glaucoma medications before surgery. After surgery, they were on about a half of glaucoma medication. And their OSDI went down to around 21, 22, which is almost to the normal state. Not quite normal, but they went from severe to mild. Which is a big deal, and less medications as well.
Yeah, got it. And we're going to go to a section here after a little bit about, and I'm going to propose to you guys what you would want if it were your eye in different, scenarios. And I think that'll be really fun. But Lori, you talked about big bad glaucoma surgeries. What would you want to have done prior to having one of those big bad glaucoma surgeries? So first, tell us what the big bad glaucoma surgeries are. Why are they big and bad? Are they all bad? And then what would you want to try first?
Yeah, and I feel bad calling them big and bad because they're wonderful surgeries when they work well and you don't have any issues postoperatively, and they can be great for controlling pressure long term. So disclaimer. But generally people think like trabeculectomy as like the big and scary, right? Because you're creating a controlled flap in the eye wall, and that can be hard postoperatively to predict and to control. Hypotony, hemorrhagic issues, scarring, things like that. It might not work after all that. And then tube surgeries. So you're sticking a foreign object under their conj into their anterior chamber, and the cornea doesn't like it. And so it's a great surgery when it works, but there's certainly issues that can come up with it. So what I would want if a surgeon was presenting that... Sir,
I'm going to pause you for a second. No, you don't need to be sorry. I interrupted. But so trabs, tubes, what about Zens? Do you put a Zen in the big bad category? And I know you said they aren't that bad or that big, and I agree, but they can have devastating consequences, and you're living with those consequences for the rest of your life. But my real question is, okay, you talked about tubes and trabs, both subconjunctival. connecting the inside of the eye underneath the conjunctiva, both with a bleb. You put Zen in that category.
I do not. I definitely think of Zen as a tick above MIGS, our ab interno surgeries, but Zen to me has a great safety profile. It's very predictable postoperatively. It's cornea friendly, and you don't get as many of those dreaded complications. It's not scot-free, but the rates of those things going wrong are a lot lower. So no, I don't think of Zen as big bad. Zen is my friend. I like Zen.
Okay, I'm going to pause just there and then get back to the question that I asked you. Mike, Zen in the big bad category?
No, I'd put it in between. I'm making a third category in the middle.
Yeah. Okay. Justin?
Yeah, no, I wouldn't put it in big bad category.
I'm the outlier here. I probably would. I agree that it's not as it's the safest tier.
Best to the worst.
It's the best of the worst, I think. And then so going back to the question I asked you, what would you want done before you do those, Lori, do the big bad ones? Does that also apply to Zen if it's not in the big bad category? So go ahead.
I'll say this, Zen to me is the worst mistake you can make with Zen is trying to get too much out of it. So if you're delaying the treatment the patient needs, if they really need a big bad surgery and you're saying, I'm too afraid to do that, so I'm going to try a Zen instead, you might be denying them the pressure control they really need. So that to me is the biggest risk with Zen. So for me personally, before I would have, a trab or a tube, I'd want to make sure for sure, like we talked about, my field is truly progressing. We're on track with my IOP target, and there's nothing I'm doing at home, lifestyle-wise, to make my glaucoma worse. The other thing is I would want to try SLT or MIGS if my nerve can tolerate that sort of intermittent step. So I wouldn't want to go straight to that. Even if I had severe disease, I think I'd still want to try something smaller because I believe with a little combination of drops and MIGS, you can get patients controlled for a while.
You got it. So what I think that I heard there is I would want to try basically everything before going to tube or trab or probably even Zen.
Yeah, I think that's right. I mean, Zen takes up a quadrant of tissue. And so, yeah, before I play that piece, I would want to make sure we're exhausting the proper options.
Justin, Mitch, would you disagree?
No. I agree. I mean, I agree. I would rather do angle-based surgeries, your stents, your goniotomies, exhaust those before moving, to Zen. I still don't put it in the big bad category. I mean, I think it's just a tier below big and bad.
Last, yeah, I continue to think it's the best of the worst. Mike said it better than I did. Okay, real quick for the last minute of this part on treatments. Justin, let's talk about eye drops for a second. Which eye drop do you use first?
Prostaglandins as a category, is that what you're asking?
Yeah.
Yeah, prostaglandins still in our first line category drops to use.
What do you use second?
Second line, I typically go to a combination agent just because I'm someone that does not plan on using 3 drops on a patient. I have you right next door to me, and so if I'm going to a third drop, I'm typically thinking MIGS anyways, and so I go to a combo agent, added to a prostaglandin. If I can't get control, then they're likely having some type of procedure.
Do you have a particular combo that you like better than the other, or doesn't matter?
It doesn't matter to me. I mean, I pay attention to, systemic side effects. I'm going to try to avoid beta blockers if there's concerns there. So I'll do sometimes I'll use one without a beta blocker. If there's no concerns, I'll use them with a beta blocker.
And then if you do have to add a third med, then what are you going to?
If I'm adding a third medication onto
Third
that,
bottle, because you already have 3 meds, so third bottle.
yeah. So the third bottle will be whatever's not in that combo agent that I can add to it. Because some of them will have a CAI, some will have, an alpha agonist. So whatever's not in that, that's what I'll do there. Or
The rock inhibitors are
combine
great.
them, with a compounding pharmacy. There's some non-preserved ones as well.
Yeah, let's talk about that for a second. So there's compounding pharmacies that will put together all of the drops in one bottle, or all the drops that are off patent anyway, in one bottle. What's your experience been with that?
It's been decent. It's not my go-to. It's a lot of times a little bit of a Hail Mary sometimes, but it's for patients that are suffering from those quality of life issues I talked about that aren't ready for a surgery, or we can't do a surgery on them for whatever reason it may be. And I can hopefully improve adherence because all those are in one bottle and you watch them closely and hope you get the pressure control you need.
Yeah, one of the challenges we think about with those is that prostaglandins are usually once a day, other medications maybe multiple times a day. When I was a resident at the Durham VA, it taught me that I'll take what's doable over what's perfect every time. And so, although I'd like to have both, I'll take what's pragmatic and doable because it actually gets done. Last question to you, Mike. Drug delivery. Durista, very exciting now. iDose was just approved. Big picture is Durista is going to last 4 to 6 months. 70% of people will still have effect at 6 months. Looks like if the phase 3 data holds with what the phase 2 data showed, that'll be similar for iDose, except for iDose will be 70% last 3 years instead of 6 months, so roughly 6 times longer. When do you think, where are these going to play a role in the treatment algorithm?
Yeah, I think they're great. And so I think they'll play a big role in the treatment algorithm. For me, the performing the iDose, you go inside the eye, slightly bigger incision than, than the Durista. But anytime you're going into the eye for cataract plus MIGS or standalone MIGS, you're adding in the iDose and getting that really long sustained release delivery. You've got someone that you got to elevate treatment on, like you just mentioned, like what's your second drop, what's your third drop. In my mind, as we were talking about those questions, it's I'm not adding a second, third bottle. I'm doing this procedure with iDose or Durista, but probably iDose because, for me, less is more, meaning I can go in the eye one time and get a lot longer duration of it. And so so to me, that's where there's a lot of places where they fit. And I think it's great that it's got so much flexibility.
Justin or Lori, anything to add or disagree with?
I'll just comment, some of my favorite patients in clinic right now are using these drug delivery devices that have, quality of life issues, just giving them what I like to refer to as a drop holiday, a break. They're so thankful for it. It's not a long-term therapy right now and a forever treatment, but it's amazing how much you can clean up the ocular surface. And I also love to use it when we're preparing a patient for surgery, when you're going to do a surgery on them, like a Zen, where they're hot, they're inflamed. If we can get that calmed down, the chances of them doing better is good too. So they definitely serve a purpose.
Lori, any comments on that?
No, I just wanted to push you on something. I'm just curious. We can cut this out if you don't want,
No.
or we can paste it in. We can paste it in earlier. But I want to loop back to why you think Zen is big and bad. We didn't hear why.
Yeah. I've had complications with Zen. Suprachoroidal hemorrhage, hypotony that lasts for a while, exposed shunts. And to me, that side effect profile that does occur with these, and I've seen it with folks that not just ones that I've done, but others have done. So I don't think it's just me. It might be me more, but hopefully not. That side effect profile that is present with Zen that isn't present with canal-based procedures is what puts it in the big bad category for me. And I wouldn't go to that unless I had exhausted the other options first.
Okay, that's fair.
Messing with the conjunctiva. Yeah.
Yeah, I think that, somebody told me once that surgeons cut, God heals. And I think that any time that we're reliant on healing there's some risk there because we don't have as much control over it. Just to be real clear, by no means was I blaming God or suggesting that we're better than God is. Okay, let's move into what I think might be the most fun part, which is what would you do if it was your eye? And real concise answers here, guys. Let's start with this. You're 45 years old. Your pressure's 25. You live close to an ophthalmologist or close to an SLT, let's say. What treatment do you want to start with, Justin?
Maybe nothing. Do I have any OCT loss or visual field changes? Anything at all?
No, normal OCT, normal visual field, pressure 25.
You say OCT is normal? Sorry.
Both are normal.
Yeah, I'd sit on it. I'd watch it.
Lori?
I have extremely thin corneas, and I probably have a really low hysteresis, so I would probably elect to treat with SLT.
Mike?
Yeah, same as Lori. I would treat with SLT. I've got family history of glaucoma.
Okay, now we've got a little bit of red on that OCT or just a little bit of thinning. Justin, do you change anything?
At 45, yeah, I'm gonna do SLT.
Lori and Mike, same thing as what you did before? Yep.
Yep.
Okay,
Yes.
so you do the SLT and you get 1 millimeter of mercury decrease from it. What do you do next, Mike?
How long has it been?
That was a year afterwards.
I'd repeat it.
Repeat the SLT. Yeah, okay, Lori?
That's a great thought. I would consider that as well, but I'd probably be looking at a drop that won't change my iris color.
Ooh. And okay, tell me more.
Um, this makes me sound really vain, but I have like hazel eyes, and so if anyone's going to change to brown with a prostaglandin, it'd be me. And I don't want to lose my hazel eyes. So I have patients that say this all the time. So, and I don't want to do Timolol either because I have a super low blood pressure. Like if I stood up right now, I'd probably pass out. But so I'd probably do, I don't know, I might try bromonidine or something like that.
Yeah, okay, wow. And that just goes to show how much better doctors women are than men most of the time. Because I would guess that most of us with that defective Y chromosome wouldn't, think about this nearly as much as we probably should have. Justin.
Yeah, I'd consider repeat, but it sounds like it wasn't very effective if you only got, 1 millimeter, I think is what you said, of mercury drop. So I'm probably going to a drop. And to your point, John, I would do a PGA. And that sounds like a bad decision right now.
Wow, Justin.
Lose.
Yeah, for sure. Okay, great. So now fast forward, instead of being 45, you're 68. Same story. You've got a little bit of change on your visual field. You're not on any medications. You do have an early cataract. You're not on any meds. Justin, what are you doing?
I want to know how concise. I want to know how much the cataract's bothering the patient. If there's visual complaint for me, I add a drop,
Yeah,
and
I don't mind. I don't mind my vision. It's just that sometimes those headlights at night bug me.
yeah,
But I
then
don't
I'm
mind.
moving forward. I'm moving forward with cataract plus MIGS. I'll start a drop and then cataract plus MIGS. Stents in my case, to be specific, I would recommend stents plus cataract surgery.
Okay, Lori.
I would do the same thing, but I'd probably want to pair viscodilation with a stent because I just feel like I would need a low target.
Mike.
I would do cataract plus goniotomy and an iDose because I'm not on drops, you said. So I'm conscious of insurance and worried about not getting coverage. So I'm going goniotomy plus
Got it.
iDose.
And so I'm going to push at you for a second, Mike, because I agree with Justin. I do stents and cataract surgery, and I'm probably not doing an iDose yet.
I want really low pressure like Lori, and I want to ensure that I don't need to add a drop back on. Keep going.
Okay, sounds good. And so why not, I think that one of the things that I like, presumably this is optometrists watching this podcast, what I want is as much freedom to use the treatment that I think is best. So do you think that the better treatment is a goniotomy in that scenario, or do you think the better treatment is a stent? And I would say that I think the better treatment is a stent, and so I would want them to be put on a drop so that I do have all of my options, so that the artificiality of the insurance reimbursement world doesn't dictate what the right treatment is.
Why do you, before I answer, I'm going to ask you a question. Why do you feel stent greater than goniotomy?
The safety profile and the high quality data that exists.
Yeah. And so I don't disagree with you. I think both
Do
would
you
be great.
agree with me?
Yeah, I agree with you. Well, I don't want to agree with you.
Well, I don't know.
No, I'm just kidding. The beautiful thing is, I mean, they're so close in their safety profile and they're so close in their effectiveness that you can't go wrong. And I just
Can I
wanted
add
to give a
another
different
thing?
answer. I wanted to give a different answer than Justin.
Can I can I give another angle to this? Because we're, again,
Nice pun.
as optometrists watching this podcast and you're talking to your patients, I think the other thing is by jumping to a goniotomy, I always think about this for you, John, is I don't want to remove other options for you down the road. And if we strip that drainage system, I've removed the option of probably you putting stents in. I mean, you'd have to find a different part of the angle. But by doing stents first, now I know down the road that you could come back and do a goniotomy in between the stents, or you can remove the stents and do it around there. And so I always think about it as how many treatment options can I preserve for the future for that patient? Less about efficacy and which one's better or not better. They're probably equally as good, but what's the right order to do it to preserve more options for my patient in the long term?
I just want a bigger straw in there. I want to get that defective TM out.
Yeah, sounds good. Now, Lori, you said you figured you needed, in particular, a low pressure. Is there any reason why? I presume it's around your low blood pressure.
Yeah, I just feel like I'm set up for NTG. So I'm actually just hoping you're going to cure NTG by the time I'm 68. But
Got you.
yeah, super low blood pressure, thin corneas, migraines, Raynaud's. I got it all. I'm like the textbook. So I feel like I'm going to need a low pressure. So to quote Paul Singh, who says he's always going to hedge his bets, I think if we're in there doing a stent, I'd want to go ahead and flush out that outflow system with some viscodilation. I think it's a nice thing to pair with stents, and you don't really eliminate any downstream options, like Justin was saying.
I'm going to push on you a little bit, but I'll come back and step back from my pushing back in a second. Are you doing that more theoretically and philosophically, or are you doing that more evidence-based?
I mean, I'll admit it's more
Yeah.
philosophical. Yeah, we don't have any data to support that really. I mean, we know viscodilation can work for several years, and we know stents can work for several years. We know that most of the resistance is at the trabecular meshwork, but not all of it. And so full system flushing makes sense.
And, I feel like sometimes people use evidence-based as a weapon to make other people feel bad. And that's not the reality of it. And so how I think about it, and when we train our fellows, we talk about the decision that you make really boils down to what would you do if it was your eye? And that's why we're asking the question this way. And our job is to take the evidence, our experience, our ability to think what makes sense, and put that all into what's right for that one patient. So there isn't evidence that covers every situation. And you've got low blood pressure. Well, they didn't sort out people that had low blood pressure and Raynaud's in these studies. And so we have to make these judgments based on all this stuff. Let's go to angle closure. You're 40 years old. You've got a narrow angle. It's got some PAS. You are plano. What do you want? Justin?
That's a tough one. I mean, the Eagle trial, as Lori referred to earlier, would be remove it and move forward, but I don't think at that age I would want that, so I would prefer an LPI.
Okay. Lori?
I think that, can I still accommodate? Am I in readers?
You're 40. So
40,
yeah, you can still accommodate it. But it's
Okay.
going along.
Yeah. So I think most of the time, as long as you're under the care of an ophthalmologist or an optometrist that's monitoring your OCT and your angle closure can be kind of caught and intervened on at the right time. So if I just have some PAS, I think LPI is reasonable to wait and see what the angle does over time. But yeah, I would hate to lose that accommodation just for some PAS. Like those are technically, okay, they're not harmless because they're impacting outflow. But if they aren't too broad and extensive, I think I would probably just hold off.
Okay. Mike?
But yeah, I'm taking that lens out. I'm putting in a multifocal IOL. I'm having you do some goniosynechial and probably popping in a couple stents because we're in there, and I'm living the good life. I can sleep at night. I don't have to worry about pressure spikes, PAS. I've fixed 2 problems very safely.
Heal with steel, baby.
That's right.
All right. Okay, so now, Justin, you're a +4.
Yeah, I'm going ice route.
Yeah, Lori,
Oh,
plus
plus
4.
four. I'm going Mike's route.
Yeah, for sure. Agree with that. I mean, it's a great chance to get yourself some free refractive surgery right there.
Minus 4.
Same.
I'm
Yeah.
sticking with my first answer on that one.
Okay. Plano, age 55.
Take the lens out for me.
Yeah, same here.
Lori?
I mean, that's Eagle trial. I believe everybody was 50 or older. So, yeah, hands down.
Okay. So I think that what we've all agreed on is that well, not all agreed. Mike didn't agree and I didn't say. But uh, if you're Plano and have accommodation still, it's not a no-brainer. If you aren't Plano or you've lost a combination or accommodation, take out the lens. So I think that that's where we're at. Now, let's go back to that 55-year-old Plano, whatever, minus 1. What lens are you having, Justin?
Any visual field loss or anything? Is this glaucoma or is this just
This is
narrowing?
this is mild glaucoma. Keep in mind, mild glaucoma has damage to the optic nerve, but no visual field loss.
So no visual field loss. Any implant is open for me. So, for me personally, because I've had previous refractive surgery and I would do light adjustable lens for me. But
Ah,
any implant's open in that case, in my mind.
okay, Lori.
I think I go back and forth daily on this. I just had a conversation with John Gertz in Omaha yesterday about what lens we would pick for ourselves. Assuming that we're kind of curing my disease by taking out my lens and that my glaucoma is not going to progress, I would I'd be tempted to do PanOptics, but I have also had refractive surgery. So LAL would be on the table as well for me.
Mike.
Yeah. I mean, echoing what those guys said, but to be different, I would do trifocal. Good news, there's studies out there that show patients with mild glaucoma, as John mentioned, no visual field loss, they do really, really well with these trifocals. They maybe have a touch more glare and maybe don't get as much near, but they still get really good range. And a little teaser, we're doing a study across some of the Vance Thompson sites asking patients, patient-reported outcomes, how much do you like your selection of your lens? Was it whether it was a toric, LAL, multifocal, whatever, in these patients that also had glaucoma surgery at the same time. And so we'll know more on that once we get that data, and we'll certainly share it. But in general, yeah, these people have lots of options. It's great.
I would also have a trifocal for sure. Currently that'd be the Panoptics for what's available currently is what I would have in my eye. And I think that one of the keys is like that philosopher Yogi Berra said, predicting the future is easy, being right is hard. And I think that the key piece, if you're gonna even start to push the limits on some of these technologies, is having a surgeon that can do an IOL exchange, safely and with impunity. And so I think of it like you're giving giving a patient a shot at the vision they want to have for the rest of their life. And if you don't even give them that shot, that's probably a miss. And so we as surgeons have to be able to do an IOL exchange and be willing to do it, especially if we're going to push the limits on the technology a little bit. Okay, you got bad glaucoma. You've had cataract surgery. You've had MIGS. Maybe you've had another MIGS. You're on full drops. Things are getting worse. You're 75. Your pressure is 17 and getting worse. Lori, what surgery are you having?
Zen.
Justin?
Zen.
Mike?
Um, yeah, man, I I'm kind of
And
thinking micropulse. Uh,
micropulse.
yeah, non-invasive. See what we can get. Uh, and if it doesn't work or I don't get to where I need to, then I still got Zen tube in my back pocket.
Okay, great. I'm doing a Zen. What, if it was me, what if that pressure was 13? Does that change your mind, Lori?
Yeah, if I'm progressing at 13 and we're really confident of that, I would probably sign myself up for a trabeculectomy.
Justin?
I'd probably still try Zen. educate the patient. I'm going to watch you really closely, and on the horizon is probably a more aggressive surgery.
Tuberate Mike, micropulse. Do you
Yeah.
call it micropulse just because it says Mike in it?
Yes. Yes. I'm probably doing the same thing, and I'm also starting to look real hard on what future treatments are coming and what other lifestyle things I can do because pressure at 13 is hard to get a lot lower to make it worthwhile, and so I'm checking out what else is available.
Yeah. And when you look across the MIGS literature, MIGS devices don't consistently get you below 15 or 16 typically. And that makes sense because there's episcleral venous pressure as a back pressure. And so really, they don't work as well in normal tension glaucoma or glaucoma that needs to be kind of in below 15 or 16. I don't mind trying it because some patients do get better than that, but I don't. I'm doing that to give them a shot at a safer surgery. Any other what would I do if it was my eye questions that you guys have that you think would be helpful to the optometry listening community?
I, we didn't
What
touch
about
much on
pseudophase?
pseudoexfoliation,
Okay.
um, and not that you treat have different treatments available for it, but man, pseudoexfoliation can get really bad really fast, and so that's where being aware of it, identifying it, treating appropriately, and treating early really makes a difference. And I think with all the glaucomas, just early treatment is key, early intervention, so these people don't lose any function.
So let's just talk about that for a brief second. Pseudoexfoliation, in the upper Midwest where we practiced, where it's pretty homogenous, and there's not a lot of African American glaucoma, it's a little easier to treat glaucoma because African American glaucoma is harder to treat. That said, pseudoexfoliation can be very difficult to treat, and we have a lot of that up in our neck of the woods, especially because of the Northern European populations. A couple of thoughts. One, Mike, I couldn't agree more that the real goal that we have in glaucoma is make sure people are sighted when they pass away and that they've lived a visually full life. That's our goal. And so towards that, MIGS may buy us 10 years, may buy us 2 years, may buy us 20 years. But the longer we can push off doing more aggressive surgeries, the better. And in particular, in pseudoexfoliation, because those zonules are weak a lot of times. And when you change those flow dynamics, you can see that lens moving all around the place, coming forward, being in a different position. And so even though pseudox is aggressive, I really don't like doing aggressive glaucoma surgeries in them, even though we have to, because their lens isn't stable.
Agree. I think you mentioned the lens moving around, the vitreous can move around too, which is even more of a pain in the butt, in my opinion, is if you do a beautiful trab and there's vitreous in the AC the next day. So yeah, I think earlier intervention is awesome in those folks, but we know that pseudox gets even harder as you get older. And those really elderly folks, 80s, 90s, that walk into your clinic with high pressures, it's really hard to stomach signing them up for a big incisional surgery. So Mike mentioned micropulse. I think, thank God we have non-invasive cyclophotocoagulation for that age group, and I've used it several times in that situation.
Yeah, and one of the things that's interesting for cyclophotocoagulation, and I don't know, do you do ECP, Lori?
I do not. I mean, I will occasionally for plateau, but I don't routinely use it for pressure lowering.
So it's not particularly satisfying to me when I do the surgery. It's cool to look at, but it's not really satisfying. So we did a study combining ECP with stents, and it worked better. And I was kind of, if I was being real honest, subconsciously hoping it wouldn't work better so I didn't have to use it anymore, but it did work better, and I like that for my patients, so we use it a fair amount. One thing that's really interesting is you see all that pseudox debris on the ciliary body, and it doesn't absorb as well. What I'm interested to know is if an externally applied cyclophotocoagulation isn't affected by that debris that's over the top and is more effective in those situations. And by the way, you don't have to be mucking around underneath the iris close to the lens. We're going to move on to postoperative care, and in the next 8 minutes or so, let's talk about postoperative care And what I'd like to do is have you give your three biggest tips, each of you. So take a second here. I'm going to put Justin on the spot first. Justin, what are your three biggest tips to optometrists managing postoperative glaucoma? You get to pick what the surgery was, but what do you want to make sure that they're doing?
Number one, educate on the front end that with any MIGS procedure, there can be some hyphema. So patients' vision can be cloudy right after. Patients like to know that before, not after. Two, just leave them on their glaucoma medications for about a month and get through that kind of first month with steroid spikes, those types of things. And then educate patients that it could take up to 3 months before we really know what their true pressure is going to be.
Great, that was concise. Lori.
I would say my number one pearl is postoperative precautions. I am extremely strict with this, even for stents, and it saved me a lot of heartache. So the first 24 hours after a stenting or a cutting MIGS, I think is really crucial that the pressure doesn't drop. So I counsel patients that first night to even sleep upright. Don't do any bending at all, even getting out of a recliner, things like that. You need to be really careful. And I think it's really reduced hyphema rates for me to really be strict with them at that first 24 hours. And then at the 1 day appointment, if they're looking good, I typically kind of move them back to more cataract type precautions.
Okay, so that was one, but I'm going to push back on you. I don't do any of that.
No?
No,
I
I'm like, life's for living. Go live your life. Maybe, don't jump out of an airplane or do cartwheels the first day after surgery, um,
but it's
and
24 hours and there's no hyphemas afterwards.
but
So
I feel like, okay, good. Keep going, push back.
so for me personally, I hate dealing with hyphemas after MIGS. And so
Yeah,
I'd much rather,
even more.
yeah,
So to be fair,
it's,
they did even more.
especially these patients who are signing up for a premium lens, they're expecting a rapid visual recovery. If they can invest that first night, first 24 hours for me to just take it easy, and I hate sleeping upright. Everybody does. But that personally for me has resulted in a reduction in hyphema. I feel like I rarely see hyphema, even with my goniotomies. And it's only 24 hours. It's not like the full week. Obviously I don't want them going to the gym and doing 200-pound deadlifts like you do every day, John, but that sort of thing.
Okay, great. So there's number one. Real quick before we get to your two and three, Justin and Mike, do you guys take that precaution, or is this another example of Lori being a better doctor than us and caring more, and thinking through the problem better?
I don't
Yeah, no.
follow those. I just say take it easy, but do your thing.
Yeah. So yes, and so no, you disagree, and yes, she's better. Okay.
Yes.
Number two.
I hate this. I was hoping you would avoid asking me 2 and 3 because I actually stop pressure meds after surgery as well. So I do the opposite. And I know we should all be united on this, but I think it's a pretty controversial thing in glaucoma care. Again, it all goes back to hyphemas for me. If their nerve is not sick enough, or if their nerve is healthy, let me not do a double negative. If their nerve is healthy enough to tolerate a pressure spike, I'd much rather them spike up a little bit at their 1 week appointment where we're going to be seeing them, or somebody will be seeing them anyways, than deal with a hyphema. And so I feel like if you let that pressure run a little bit higher, their reflux for hyphema and what that causes hyphemas is less likely. So I go the opposite. I stop pressure meds. If they're high and I can avoid adding back a med, I just start their steroid taper a little faster. And then I wait as long as I can to put them back on meds. It just works better in my brain this way rather than tapering them off later. And I'm actually in the minority on this.
Yeah. Do you stop blood thinners for MIGS?
If it's an over-the-counter, like not doctor prescribed aspirin or vitamin, I do. I tell them to go off of it. Why not make it as safe as possible?
What about doctor prescribed warfarin? What is the new one called Xarelto?
Yeah.
Do you stop those?
I try to. If I really, really want to do like a cutting mix on them, like a goniotomy, I will try to stop them. If they cannot come off of their blood thinners at all, I will still consider doing a 180 goniotomy, but like a 360 goniotomy, no way.
Got it. Justin, Mike?
I don't stop blood thinners for any MIGs, but Lori, I do the same as you. I have them stop their glaucoma drops and start their, new journey without any drops and then add back on as need.
True, even if they are on 2 or 3, Mike, when you're doing an early MIGS treatment, you stop everything and then just
Yeah.
add back if needed. Yeah,
Yep.
okay. Justin, do you stop blood thinners?
No, no. And high femurs to me just don't worry me that much, only probably because I see them often enough. But I get it. I mean, I just tell patients it's gonna be there for a week, and after a week, it's gonna go away. I just try to keep things as simple as possible. That's why I don't drop meds either until about a month. Again, there's no cookbook recipe on any of this stuff, right? And we think about MIGS and postoperative care, it's still in its infancy. It's only been around for 10 years. And so it's fun having these conversations because you learn something new every time.
One of the phrases that I love is that there's those that follow the standard of care and there's those that set the standard of care. And we try to be a practice that helps set the standard of care. And so, I think that what would convince all of us, and toward your point, Justin, is we don't know. We don't know if elevating the head at night is better or not. We don't know if stopping blood thinners is better or not. We don't know the consequence on the other side of those things. And I do think that these things are here with us and here with us to stay. So if we can create a patient-centric postoperative regimen that has some evidence behind us, I think that we can all make better decisions. Lori, number 3?
Number 3, Pearl. Those are my main post-op pearls for phaco MIGS, I think.
Okay, what about phaco not MIGS or not MIGS glaucoma surgery?
Okay, so for blood-based surgeries, I would say that managing the ocular surface ahead of time is your best way for success there.
Okay, great.
Yeah.
Great. I don't think any of us will disagree with you on that one. Mike?
That's why I
and
picked it. I am so conflict averse. I'm like sweating. Are we done yet?
Well, you sliced and diced us all up pretty effectively, Lori. So good job, Mike. What's your 3?
Yeah, going last is hardest because
I'll
everybody's
go
taking.
last. I'll pull up the anchor for you, and I'll give my top 3.
Thank you. I hope I take the 3 that you're thinking of. Um, don't be scared of pressures going up and down in the post-op period all the way up to a month because, like Justin said, it takes 3 months. So just ride that wave, adjust meds as you need to based on severity of glaucoma. Continue to follow these patients. They still have glaucoma, even if they're off drops and their pressure is perfect. You still need to follow them again based on their severity with your testing. And I do like a 3-month kind of reset. That's a great time to reset with your OCTs, visual fields, and then continue to do gonioscopy. If we've had MIGS surgery, you still got to check and make sure that the angle's looking good.
Anybody disagree with anything Mike had to say? That's
No.
probably because he was too vanilla. So here.
Are you talking about this or my answers?
Well, I just was wondering, was your screen? Do you have some sort of pale filter on your camera?
I wish I could say that, but I don't.
I think Mike looks glowing today. I think he
Yeah,
looks great.
Mike, you look great.
Thanks, Bree.
Okay, so here's my 3. Number 1, call. Just call us. We're all on the same team here, buddy. And so if there's a question that you have, we don't want you to be anxious at night. We don't want the patient to be anxious at night. And of course, we all want the best outcome. So don't hesitate to call any one of us that were involved in the care to make a decision. Number 2, bleb-based surgery. There is a window where we can rescue blebs that can go away as that bleb starts to scar down. And so be looking for lowering of that bleb, vascularization of that bleb, redness, eye pressure going up, and call or send a picture. Because we just did this big glaucoma surgery on these patients and we really want to give that surgery. every ability to survive. And then last is a little bit of a variation on what Mike said. We as humans aren't great at preventing vision loss. Primary care doctors don't get gift baskets from their patients because they put them on a blood pressure med and save their life because they don't know that it did. And we don't get baskets from our patients for putting them on an IOP lowering med. We get baskets for taking out their cataract or doing their cornea transplant because we made their life better. And my point here is that a lot of these are combined with cataract surgery, and patients see better maybe than they ever had in their whole life. And their tendency may be that they always went to the eye doctor just because they needed a new pair of glasses. And that might have gone away. So to reemphasize what Mike said, glaucoma patients need to be followed for a lifetime, and we need to make sure that they're seeing you and us when we're necessary to give them the best care possible. And those would be my three biggest tips for postoperative care. Anybody want to push back on those?
Nada.
All right, let's give one last thought around the table to everybody. I'll go first, and that is we need to intervene in glaucoma. I'll go even more broad. The right question to ask yourself is, what would you want if it was your eye? That takes into account everything. Our job as doctors is to keep patients living their best life possible, and their best life possible is not in the doctor's office. So our job is to keep them out there living their life as best as they possibly can. Mike?
Same vein, opportunity for cataract plus MIGS surgery in people that are good candidates for refractive cataract and MIGS to, give them independence of glasses if that's something they desire, and independence of drops can really make a difference in quality of life.
Lori?
I think treating glaucoma is sort of turned into it takes a village. So what I've learned is it's often the referring doc, it's the surgeon, it's the family member, it's the patient, sometimes it's their caregiver. So it takes a whole bunch of people to take care of one person's disease. And so I try and keep all that in mind, especially when it comes to involving the family and decisions. I try and always think of what the patient's like outside the office. Like you said, John, I think, how is my treatment going to impact them when they're not in here? And thankfully, we have all sorts of treatment options now that are a lot less invasive and a lot more patient friendly and better for quality of life. So it's a little more fun than it used to be to take care of glaucoma because we can actually make things better instead of just trying to slow down things from getting worse.
Justin, bring us home.
Yeah, I'll go to the diagnostic piece. IOP matters, but don't let it dictate everything you do. Think of glaucoma like a large puzzle. You have a lot of pieces that you can use to decide on your treatment options. And think about the quality of life of these patients when you choose those treatment options.
All right, everybody, this is fun. It's great hanging out with you guys. To the listeners, if you want more, we've got more. Schedule a personalized mini fellowship with us. And what that is a half day where you come, or even a full day. You can get some COPE credits for it. Immerse yourself in hands-on learning, gain insights from all of us. It'll be intense because you'll see all of the patients that we see in that day and the decisions that we have to and get to make, and take the next step towards elevating your own game. And so with that, remember, the world of eye care is ever evolving, and so are we. And so until next time, on behalf of Lori, Justin, Mike, and me, thanks for being with us. And there's a whole bunch of stuff on our website to keep you updated on whatever the newest things are. Thanks again, and have a great day.
Love you guys.